Good. I'm starting the timer and here is your question. Right, so if you have read and understood, considering it's surgical and not mistake, kindly identify, oops, I'm sorry, kindly identify these structures from A to D, please, E, sorry. What are you looking at?
Is the cecum, B is the appendix,
Okay.
C is the mesoappendix, D is the ileum, and E is the mesentery.
All right, okay. Can you please tell me the anterior attachment of small intestine? Anterior relation, I'm sorry, anterior relation of the small intestine.
Of which small intestine?
Yes, please.
Anteriorly, it is mainly covered by greater omentum. Sorry, greater omentum.
And which other muscles of anterior abdominal wall you have to tell me, because that's what that is. After omentum and peritoneum, then what comes?
And the muscles of the anterior abdomen. In the midline, we have rectus abdominis, and on the lateral side, we have 3 layers muscle: the external abdominis, internal abdominis, and
yes.
transversus abdominis.
How is it layered?
From outside to inward, it's skin,
Yes.
superficial fascia.
Yes. Yes, please.
Fascia transversalis, preperitoneal fat, and parietal peritoneum.
All right, okay. Can you please tell me the origin or the development of small intestine?
Small intestine is developed from the midgut.
Okay. A whole of it?
No, from the
Please. Yes.
from the part distal to the ample furter, and
Okay.
until the 2/3 of the transverse colon.
Can you please tell me what is appendicitis?
Appendicitis, it is the inflammation of the appendix.
Yes. What is appendix? What type of organ
Appendix,
is that?
it is a vestigial organ.
Yes.
It is a vestigial organ which is located at the level of the
what are the
cecum,
most common positions
below
of
the
appendix?
ileocecal.
What are the most
common position is retrocecal. The other positions are subcecal. The most common is retrocecal. The others are subcecal, pre-ileal, post-ileal, then pelvic,
yes,
and
okay.
inguinal.
What is the blood supply of appendix?
Appendix is supplied by appendicular artery, which is the branch of ileocholic artery.
Okay, can you please tell me When there is appendicitis, why the pain is referred to umbilicus?
Initially, the visceral pain is referred to the umbilicus because the visceral pain is conveyed through the spinal nerve that adjusts at the level of T10, because the T10 dermatome lies across the umbilicus. That's why the visceral pain is initially felt there. Then,
can you please tell me the origin of external oblique muscle?
External oblique muscle originates from the outer surface of the lower 8 ribs, and it is it runs forwards, downwards, medially, and is inserted into this diffuse sternum, linea alba, and
what is the nerve supply of external oblique muscle?
It is supplied by the lower 6 thoracic nerves.
Okay. Can you please tell me? What is this organ that you're looking at in front of you?
Surface of the diaphragm.
Okay, can you please tell me what are the common openings of the diaphragm and at what level are they located?
There are major opening and minor opening. There are 3 major openings. That is the opening for inferior vena cava at the level of T8.
Okay.
And esophageal out opening at T12.
All right. Can you please tell me what passes through, along with inferior vena cava, passes through T8 opening?
With the passes the right phrenic nerve.
Yes. What about in T10? It passes esophagus, and what else accompanies esophagus? Which opening
esophagus
is esophagus?
And the 2 vagal trunk.
This one, or this one?
The
1, 15, or 11?
15.
Okay. What passes through 1?
One descending thoracic aorta,
along with
esophageal, along with the thoracic duct, and
azygous vein, sympathetic trunk. Okay, can you please tell me the attachment of diaphragm?
Diaphragm, it originates from 3 sides: the posterior surface of diffuse sternum anteriorly, then the inner surface of lower 6 costal cartilages, and the posteriorly from the right and left crus, medial and lateral arcuate ligament, and then it inserts into the central tendon.
Okay, good. Can you tell me what are the hernias associated with the diaphragm, and why do they occur?
Basically, there are 3 types of hernia.
Yes.
One is the congenital one, so that's hernia, that usually is common on the left posterior side. Then the other one is the hernia through the foramen of Morgagni. Then another one is the hiatal hernia, where the upper part of stomach
which hernia is
through the
most
dilated
fatal?
esophageal opening.
Which hernia is most fatal?
Bogdolic hernia is more fatal.
Okay, can you please look at this diagram?
Hernia.
Can you please look at this picture and tell me what are you looking at? Can you identify structures?
Yes, ma'am. This is the upper surface of this is the thoracic cavity showing the right and left dome of diaphragm and the fibrous pericardium with the descending with the thoracic aorta.
Very good. Okay. If you can, oh, that was it. Okay. All right. Okay. What is this opening? What are you looking at?
That's the spinal cord.
Yes. And here as well. What is this 19 and what is this 3?
19 is the and the spinal nerves, root of spinal nerves.
All right, good. What is the nerve supply of diaphragm?
Diaphragm is the motor supply to whole diaphragm is from the phrenic nerve, C4-5, and the sensory supply to the central part is by phrenic nerve, and the lateral peripheral part is from the lower 6 thoracic nerves.
Good, thank you. Yes, and here
Thank
is
you.
the, not now, yours is next. This, all right, yeah, start with your question.
Okay.
Right, so if you have read and understood, considering it critical care scenario, kindly tell me, how would you manage this patient further?
I will manage according to the ATL's protocol
Yes,
using ABCD approach, check the airway, patent,
yes,
then I will move to breathing, the respiratory rate, and inspect for any wounds or obvious injury. I will do palpation for chest asymmetry, auscultate, and percussion. I will check blood pressure and blood rate. This patient is GCS is 8, so I'll go for intubation.
okay.
Once 8 intubate,
How would you set the ventilator? What would be the setting to which you'll set the ventilator for this patient?
a high flow oxygen with keep hyperventilation to maintain the partial pressure of carbon dioxide
Yes,
to control the respiratory drive.
yes. Okay, can you please tell me why patient had Glasgow Coma scale 15 when patient arrived, and after 15 minutes it decreases to 8? What has happened?
This is called lucid interval, which
Yes,
is the temporary improvement in patient condition,
yes.
after which there's the deterioration in the patient consciousness due to blood accumulating in the extradural space, which leads to cerebral edema.
All right, good. Can you tell me the pathophysiology that lies behind increased intracranial pressure?
This is called Moroccan Hypothesis.
Yes,
The skull is the rigid box, contains 3 components:
yes,
the brain and the blood and CSF.
yes,
The brain is about 80%, and the other, each of one is 10%.
yes.
Any increase of one of the components will lead to decrease in the other as the compensation.
Right.
When
Yes,
intracranial pressure is more than 25,
yes.
this
Millimeter of mercury.
will lead to failure of decompensation, which lead
Yes.
to, yes.
All right. Can you please tell me what is the normal value
Okay.
of increased intracranial pressure? What is the normal value of intracranial pressure?
Means it's combined between 7 to 15
Yes.
on
And-
standard 10 millimeter mercury.
Okay. Can you tell me if there are any ways by which you can measure intracranial pressure?
Okay, there is the invasive and non-invasive ways.
Yes.
Non-invasive, we can use transcranial ultrasound
Yes.
on the middle cerebral artery, which is conduct the middle cerebral artery velocity. And this is derived velocity index, which correlates with intracranial pressure. Invasives can use extradural drain, and also it can use subdural catheter
Yes.
and intracranial pressure transducer.
If you do CT scan.
Also, we can use intraventricular and
Yes.
intraparenchymal. Okay.
Yes. If you'll do a CT scan of this patient, how do you expect it to be? Can you read the scan, please?
Will be
Yes, please.
okay. This is biconvex hyperdense
Yes.
lesion on the right side with midline shift and with ventricular compression.
Yes. And that gives
This
you
is most likely
provisional.
extradural
Yes.
hematoma.
All right. Good. Okay. If patient has increased intracranial pressure, would you or would you not do the lumbar puncture? Would you do lumbar puncture in this condition?
To the brain herniation and canine.
All right. Okay. Can you tell
No.
me? All right. No. Can you tell me what is Cushing triad?
Cushing triad. This is composed of hypertension and bradycardia and irregular respiratory pattern.
All right. How would you
To
differentiate it from?
respiratory depression.
How would you differentiate it from Cushing reflex? What happens in Cushing reflex?
Cushing reflex. This is both stimulation of the vagus and
Yes.
sympathetic stimulation in order to increase intracranial pressure.
Yes.
In
That
order to
also.
maintain the cerebral blood flow.
Okay. That also leads to.
And this is associated with bradycardia.
Yes. Bradycardia. All right. Okay. Can you please tell me? Right. Can you please tell me how would you calculate the Glasgow Coma scale? What are the factors that you consider?
Okay, this is verbal and motor and the eye. For the eye, there is overall it is 15. The less minimum is 3 points. For the spontaneous eye opening, this is 4. If it is respond to the only vocal or voice, this is 3. If it's opening his eyes to pain, this is 2. If it's no opening, this is 1. For the motor, if patient can obey command, this is 6. Localize the pain, 5. Flexion from the pain, this is 4. Or extension, this is 3. If there is decorticate or abnormal flexion, this is 3. If it's abnormal extension, this is 2.
If patient
And
fails
there
to
is the
yes,
variable.
yes, if patient
Okay.
fails to respond to medical management, what option would you go for?
I will go for surgical, such as pair hole operation or
Yes.
craniotomy decompression.
All right. Okay. Then, all right. All right. Okay. What diuretics do you think can be beneficial for this patient in this condition? Would you restrict
We'll use
fluid
automatic
in?
diuretics
Yes.
such as mannitol.
All right. What's the action, a mode of action of mannitol? What is the mode of action?
This is the
Yes.
it is increase the secretion of sodium and water.
X where? Please
It reduces
tell
the
me.
cerebral edema.
Yes, but X at what point? Does it act somewhere in kidney or does it act right where in the brain? So you have to tell me the mode of action and right. And if there is any role of restricting
Okay.
fluid management or fluid intake in this patient, would that help or not?
Yes, I will go for fluid restriction. Yes, it will reduce the cerebral edema.
Yes. All right, good. Thank you.
Thank you.
Actually, I started and here is your question.
Shall we start? Or?
Yes, 1 minute. Read the question first, please.
Okay.
Right, so if you have read and understood, considering the communication skills station, kindly begin. Begin.
Yeah. Hello, Mrs. X. I start. Hello, Mrs. X. I'm Dr. Diaphragm, one of the surgical doctor looking after you. I'm very sorry for you have been waiting for a long time, Mr. Ali or something. No.
Hello.
Hello.
Yeah. Where is Mr. Man, please? I'm waiting for him. Are you Mr. Man?
No, I'm not. I'm one of the surgical doctor. I'm Dr. One of the surgical doctor. Dr. Man, he's called by emergency, so he couldn't see you. So I'm here to speak and discuss how can I help you. I will take all these conversation to Mr. Man. I can do an appointment for another appointment. I know you are coming with your husband coming 6 weeks before. He's suffering from tummy swelling. We taken the sample and we saw the malignant cell. We arranged for CT scan. Unfortunately, I'm sorry. I apologize. The CT not working today. So
Why? Why for? Why for? I'm waiting here for a long time, and my husband is suffering. He's suffering and he's dying. What happened? Why it's happened like this?
I'm sorry for that. Accept my apology. The CT scan is not working today. There is a technical issue, and Mr. Man he's called for an emergency. Let me to told you why you choose the CT scan. CT scan, it is as we know, as we discussed before, your husband tummy is it's distended or swallow, and when we take it, we're looking for this malignant cell. So we request this test to show where is the site for the malignancy and where it's go, and it is very important in staging and the management of the tumor. Does that make sense?
Yeah, but the time is going. It was 6 weeks back, and what is the other solution, please?
Yeah.
Last time, the doctor,
Yeah.
Mr. Man took a spit fluid from the tummy of my husband, and now he is suffering. And what is the alternative? Could you please tell me? He is suffering now.
Yes, I'm sorry to hear that. I can imagine how it's hard for you and for your husband. So you asked me about alternative. Yes, we can do ultrasound. This is the gel when they put on the tummy of the pregnant women and looking for his tummy and if there is any liver involvement or any deposition. And also we can do magnetic resonance image. It seems to be like the CT scan, but your consultant requests the CT. So if he insists on the CT scan, so we will arrange if the technical issue or problem is resolved. If that
How do you help him, please? Or can you do the CT scan for him? Can you do the CT scan?
the CT scan, it's now broken for technical. So we will figure, but we can, if we cannot do these, we can transfer the patient to hospitals for shortness of breath. Yes, exactly, because as you know, the fluid is collected in the tummy and with pressure on the lung, so it's make the breathing is more difficult.
So how can you help my
And we can
help
with that,
my husband?
Yeah, we can discuss this with Mr. Mann to aspirate some or to take the fluid from his abdomen and relieve things. Is that good for you?
Yeah. Could you please tell me my husband has having cancer?
Have the fluid and it show the malignancy cells. We need to know the stage for that and what is the site of order. It's my, according to that, he had the cancer. Sorry for that, but we need to more precise, more test to show what is the site or when it's gone.
If cancer, what is the treatment for that?
So it is the good question. We need to do according to the type of the tumor and the site for that. We can do the operation only for patients that got benefit from the surgery. But if the tumor metastasizes, cannot remove, we cannot do operation because it is out of his interest. Does that make sense?
Yeah, but what about the CT and other investigation to well, how long it take? How long it take? I'm sorry about my husband.
Yeah. Actually, our hospital is small, but I need to tell you, all our tests, we will do it in maximum time 2 weeks. So during these 2 weeks, we can arrange. If we cannot do that, we will transfer your husband to another hospital to be safe and to do the test in time.
Okay, thank you, doctor.
Okay, I will want to summarize you coming here for CT scan, but unfortunately, the CT scan not working due to technical issue. We will discuss we discuss with you alternatives such as ultrasound, CT scan, and we will discuss also your idea about to transfer the case if we cannot do MRI or alternative to the other hospital. Also, we discuss about the line of the manager looking for and we can help you.
Okay, thank you, doctor. But please put my husband in your priority, please.
With your husband, so we will do our best to do the it's finished. Okay.
Right. Yes. Can you, Dr.
Thank you very much.
give the feedback first?
I think he did well, great.
Yes.
But one of the problem is he is talking a lot. He didn't give me chance to talk. But he was covering everything, but he didn't let the wife of the patient to talk and to give the concern. I think this is only comment.
All right.
Thank
You
you very
didn't
much for
notice
this
anything else?
No,
he was
He's-
using a lot of medical terminologies, like he said, abdomen. We'll discuss with Dr. Mann, and we'll drain, he said, and then he realized in the word abdomen. But I noticed that he needs to practice using layman terminology with the patients or patient relatives, because if you keep on using medical terminologies. Not every patient
Yeah.
will understand and follow, especially in this kind of situation when you are breaking the bad news that the patient has cancer. Right, yeah, that's the only concern that I have. We'll practice more.
Yeah, he did perfect.
Okay, thank you.
Yeah.
Thank you for.
Started, and here is your question.
Okay.
Right, so if you have read and understood, considering its communication station, kindly begin.
All right. Good evening. I'm Dr. Fabian Olisa, one of the surgical registrar on call today. I'm calling with respect to a patient whose daughter wants to discharge her against medical advice. May I confirm I'm speaking with the consultant on call, general surgery consultant on call?
Yes, I am the general consultant on call. Could you summarize the case, please?
Okay, thank you. Thank you very much, doctor. I have a case of this frail elderly woman who is 78-year-old, who currently has axillary swelling, and she has shortness of breath. When I examined her today, the vital signs were within normal range. And but unfortunately, her daughter wants to take her home. Okay, and this patient has a background mild left ventricular failure and is a known COPD patient. She was actually operated upon 2 days ago for breast cancer. She had mastectomy and axillary clearance. So I'm really worried based on the situation. I think the daughter wants to. I've tried to talk to her daughter, counsel her daughter, spent up to 20 minutes trying to tell her that her decision is not in the best interest of the patient, but she seems to be not to agree with all my efforts. So for that reason, I've decided to call to seek your opinion about this current circumstance, sir.
Okay, thank you for your calling. I just want to ask if the patient competent and she can take her decision, or it's built by all pressure under pressure of another person.
Yeah, I have assessed the patient. The patient can actually take a decision on her own. She can. As a matter of fact, the patient would rather go home, go to her own apartment, where she can, after this current condition has been resolved. She was supposed to have been discharged, but we noticed that this has happened, and I convinced her to stay. But the daughter came around today and is really putting pressure on her to go. And what I found out was, I think the daughter lives far away from her, and she finds it difficult to come around to see her. But doctor, I'm really worried that the daughter is really putting so much pressure on her to go home with her, to save her that stress. So.
Okay, if she's competent. Okay, what do you think? What's happened to this patient?
Okay, this patient, I think she probably is bleeding. She may be having a secondary, no, sorry, sir, she may be having a reactionary hemorrhage, really, because this is day 2 post-op, and most likely the shortness of breath she's having, it could be exacerbation of her COPD. I also think, I don't know, I'm worried. It could be this patient may be having DVT, maybe axillary vein thrombosis also. It's just possible. Because I also noted that her drain is bloody. So with the axillary swelling, so I think she may be bleeding. She may have reactionary hemorrhage.
So what will be your plan to do for this case?
Oh, okay. My plan for her is for the possible reactionary hemorrhage, I want to do a full blood count to check her HB to see if it is dropping further. I will also do an ultrasound of the axilla to confirm that there is blood accumulation within the axilla. Preferably, I want to do a duplex ultrasound in the same sitting, so that if there is anything within the axillary vein, it will show me the flow within the axillary vein. Then if I'm still in doubt, I can also do a CT pulmonary angiography to be sure that even this shortness of breath she's having is not from a probably embolism from the axillary vein thrombosis. I will do that and possibly know what next line of action to take, sir.
Okay, thank you very much. If the patient, as you said, she is competent and she is insisted to discharge to the home, what should?
Okay, if they are still insistent on going home, what I will do is to explain the complications of their decision, explain to the daughter and also to the patient all the possible complications that she may continue to bleed from that from the axillary area, and that she may also have some breath. And once I finish doing that and explain the complications to her, I will have to give her a form, a discharge against medical advice form for her to sign. That's a legal document for her to sign. And I will as well give her I will also tell her some certain signs to look out for should there be any of those problems that we are still here to welcome her, or she can go to a nearby hospital since the daughter lives far away from this hospital, sir.
So what do you do for drain? Did you remove it, or what did you do?
No. I'm going to leave the drain in place, sir. I'm going to leave the drain in place because I really don't know what is happening at the moment. Yes, sir.
So who's take care for her at home?
If she's going with the daughter, I'm going to recommend that she goes to see a GP close to where a daughter's GP. I will recommend a referral letter to a GP close to where the daughter stays if she still insists on going with the daughter, sir. And in the referral note, I'm going to include what we have done for the patient, which is mastectomy and axillary dissection, and then the current problem, which is the axillary swelling and possible bleeding into the axilla, so that the doctor will take note of that. Yes, sir.
Okay, let her, if she insists, let her to sign the form and discharge her.
Okay.
Thank you.
Okay, may I please summarize what we just discussed, sir? I've been able to tell you about a patient, a frail elderly patient who is a known COPD with mild left ventricular failure, who has a sudden onset of axillary swelling with shortness of breath. I am concerned that she may be bleeding into the axilla and there may be possibility of pulmonary embolism. However, the daughter is insistent that she wants her discharged. And I've also discussed with you that I'm going to give them a form for referral if they so insist.
Good.
Okay.
Yes, Dr. Duffer, can you give the feedback first?
Yes, he's a good presenter. He's a good presenter. He covers everything in the in the station. He have a small. I have a small note, 2 notes about him. He mentioned to ultrasound in the note, in all notes we have. They didn't mention about ultrasound to show hematoma. This is the first one. And in the second one, in the summarizing, when we started the station, I told you to summarize the case, and you summarize the case for me. So you don't need to summarize in the end of the station. You got it?
Yes, I got it. I got it.
Okay.
Because
yeah.
First I told you to
But what
summarize.
he summarized was whatever was discussed with you in the beginning.
What
he
we
summarized,
discussed, yes.
Yes. So that was appropriate
Yes.
because this is called to consultant. In the beginning, you asked the SHO to tell
summarize
the
the case.
Yes, and at the end, just to make sure he did not miss anything, he has taken your orders correctly. So he just summarized it up for you. So that was correct. Just maybe I've missed, but correct me. Did he, when you asked him for the plan of action, did he tell you about the DVT and pulmonary embolism?
Yes, he did.
Chest
He
X-ray and
mentioned
CTPA?
no.
Yes, I did, ma'am.
All right, okay. And physiotherapy? Just physiotherapy.
No, I didn't talk about
Yes,
chest physiotherapy.
that you can also add. Okay.
Okay, ma'am.
Yes,
Okay.
that you'll contact the medical registrar and if it's needed, and then you'll also contact the physiotherapist for chest physiotherapy because now she's presenting with shortness of breath, and there could be, because it's second post-op day, so maybe she needs a physiotherapist. And at the end, yes, you did mention the warning signs. At the end, when Dr. Duffer consultant asks you who would take care of her at home, so like how to say it in English, there are home service like maids, like they are sent from the government, social service kind of thing. You send a letter to them, and that's how they know that they have to go home and check the patient if the patient is doing all right or not. And one of their duties to make sure that patient has taken the medications as well, because she's living alone kind of, and doctor is living 20 miles away somewhere. So that also you can add, that you'll inform the social services to take care of
services.
They send a kind of primary care taker at home, because in Swedish we call it hemtjänst. Like a caretaker goes home and gives the medication and makes sure the patient is okay. And if
home care nurses, something like that, right?
Yes. Social nurses or home
Thank
care
you,
nurses, something like that. Yes, good.
Thank you.
Thank you. Your timer, and here is your question. Right, so if you have read and understood, considering the history taking station, kindly begin.
Good evening, sir. I'm Dr. Kolade. I'm one of the surgical doctors here. Can I confirm your name and age, please? Dr. Ufora.
Okay, I have Smith.
Yes, can I confirm? Okay, can I confirm your age and name, please?
I'm Smith, 56-year-old.
Good.
Okay.
Yes.
All right. Sorry, I would like to ask you some questions. Hope it's comfortable by you.
Please go ahead.
Okay. So why are you here today?
Have been uncomfortable because I saw blood mixed with my urine, and I felt it was abnormal. So that is why I am here. And this has been persistent for the past 5 weeks.
Okay. All right. So the blood that you've been seeing, is it throughout your urine, or to come at the end, or at the beginning of the urine, your urine coming out?
Completely mixed with my urine.
Completely mixed with the urine. Okay, that's fine. Is there any time that the urine was clear, or it has always been blood since that last 5 weeks?
Sometimes it clears, sometimes it's bloody.
Bloody. Okay. All right. And is there any pain anywhere?
Yes. In the last 2
Okay.
days, I've been having some pain in my left side, my lower left side.
Okay. It's coming from where to where? Is the pain dull, or is colicky, or how will you describe the pain, sir?
The pain is dull.
It's dull. Okay. All right. Apart from that place, no other place where you have pain, Abby?
No.
No other places that there is pain. Okay, fine. And this blood, do you have clots also coming out at any time, or is just only mixed with urine, no clotted blood coming out?
Occasionally, I see clots.
Occasionally you see clots. Okay. All right. And any bleeding from other parts of your blood body?
No.
No. Okay. And do you have fever at any time?
No.
No. Okay. Is there any time that you had an injury in this last 5 weeks or more before this bleeding from your
Private parts.
white passing urine started?
Not at all, from what I can
Not
remember.
Okay. Is there any time that you notice that you pass stones from in your urine?
No.
That you notice? No. Okay. All right. If you go to urine and you want to urinate, do you feel maybe you have to bear down or difficulty initiating urine, or you feel
No,
that urine you don't empty fully?
no significant difficulty, but sometimes I feel such, especially when I'm passing those clots.
When you are passing those clots? Okay. Any swelling in any part of your body, especially in your tummy, or maybe in your left flank also, that you say you're having pain? Any swelling there?
Not at all.
Not at all. Okay. Do you notice whether your appetite has it reduced, or you still have good appetite?
My appetite has reduced in the last 5 weeks.
5 weeks. Okay. Do you have intentional weight loss also?
Yes, I've also noticed that.
Okay. All right. Hope no. So what is your idea about this bleeding from your urine that you notice? Any idea?
I'm just worried because I've been told by my GP that blood coming from anywhere, any part of the body, is not normal. And I'm afraid it could be something that is dangerous. Doctor, could it be dangerous?
No. Oh, well, it's possible. But we try to take our history and examine you and do investigation to find out. So any that your worry is the concern. Okay, any expectation? Do you have any expectation from us?
Yeah, definitely. I want to know what could be this to resolve.
Okay, all right. And also, sorry, I want to ask you about some personal questions about your health. Have you been hypertensive for how long now, sir?
For 6 years.
Do you know them, or you don't know that your GP is giving you?
I'm on amlodipine.
Amlodipine, all right. And apart from the hypertension, any other treatments or drugs that you are taking from your GP?
Not any.
No, okay. All right. Any surgery in the past? Have you had any? Do you react to any
I've not
drug
had any surgery.
or any drug allergy? Do you have any?
No,
Okay.
not at all.
All right. I want to ask you some personal questions. How you've been smoking now for how many years? How many sticks do you take per day?
I take one pack, and I've been doing that for the past 20 years.
20 years. Okay. All right. And do you smoke and drink alcohol? Do you drink alcohol also?
Occasionally, I take beer.
Beer. Okay. All right. Like how many grams or bottles per day?
Sometimes it depends. I take 1 to 5
Okay.
of my liquor when I want to take it.
All right. Do you take the burial to drink? Do you take burial to drink? And
No, I don't take any other.
I don't take. Okay. All right. Is there any time that you've been exposed in your factory? Do you get exposed to radiations or to dyes?
Can you summarize, please, your case now?
Okay, I've interacted with Mr. Smith, a 56-year-old man, and factory worker that presented with 5 weeks history of HAEMATURIA, painless HAEMATURIA with agitated pain on his left groin radiating on the left loin radiating to the groin with agitated weight loss and anorexia with a significant history of smoking and alcohol intake. Is also a known hypertensive on medications.
So what are your different provisional diagnoses?
Okay, I'm thinking of a renal stone, then also a renal cell carcinoma.
Okay, or urinary bladder carcinoma.
Yeah, or urinary bladder.
Yeah, all right. How do you suggest to manage this patient?
Okay,
what investigations would you do
investigations?
to confirm your
Okay,
diagnosis?
I want diagnosis. I want to do urinalysis. I want to do an abdominopelvic ultrasound, and then a CT with an IVU for the CT abdomen with an IVU also, and then urine urinalysis and urine cytology also will be, and then full blood count.
Yes. What is the treatment options that you can offer to this patient?
Yes, the treatment options will depend on the diagnosis. If it is renal cell carcinoma, we need to have depending on the stage, we need to have the patient will need a nephrectomy, left nephrectomy to be done. If it is a bladder CA, depending also on the stage, patient may need to have a transurethral bladder resection to be done, so as to remove the tumor. Then
non-surgical.
if it's renal stone, then
and
if it's renal stone, then the
Yes, please.
If it's renal stone, then nephrolithostomy will be done, or shockwave therapy to destroy the stone, and then analgesics also for the pain.
Good. Right. Dr. Tule, would you like to give feedback first? It was good first time he presented. How did you find his history taking?
Yes, ma, it was a nice attempt. Was a good attempt.
Yes.
But it was stated in the question that I had exhaustion and something that could suggest that one had features of hemodynamic compromise, which was not elicited in the history. For a patient that has been putting.
It was. He asked you if you had how was your appetite and how was if there was any unintentional weight loss or something. So that was, he tried to he tried to find the answers to these questions. No?
Yes, ma, I got that, ma. Well, what I was trying to say is for someone that's been bleeding for the past 5 weeks and the clot, it's important to know if the person has been having dizziness or easy fatigability that may suggest anemia.
Yes.
Which is also stated in the clinical scenario, which was not confirmed from the patient.
Yes. My little addition before, wait, Dr. Fabian, just a second. Right, he asked everything because in the beginning, in the middle, when he asked about ICE, idea, concern, and expectation, then he remembered and he asked past medical and past surgical history and the drug history and even the social history, because I had written patient is a factory worker. So he asked you if you were exactly the time when bell went, he asked you if you had been exposed to any dye. But one question that when he was asking you about the history of your presenting complaint, he could have asked you about the frequency, if there has been any change in the frequency, if there was like any, if you have ever experienced incontinence, or if there was like any history of nocturia, like in the middle of the night you had to rush for the loo. So, and then if when you told the pain, he asked you what type of pain it is, dull or colicky or whatever. Then he could have asked you to scale the pain from 0 to 10.
Okay,
Yeah, that small thing. Constitutional symptoms he did ask, but like with that he could have asked about the fever with chill, just to rule out if patient has any UTI or something. That's it.
I have the fever, ma.
He did say fever. Okay.
Yes, ma.
You asked fever. Okay, I'm sorry. Yes, all right. Yes, Dr. Fabian, you want to add something?
Okay.
Yes.
Thank you very much, Shegun. I want to. You did very well, but I
Yes.
want to make one or two contributions. You started after the introduction. You started with sorry. I just feel you should watch that. As you started with sorry, there's really nothing to be sorry about. You are the doctor. You know, you should just go ahead and tell the patient straight on what you want to do. And I noticed throughout your conversation, from your words, you kept saying that is fine, okay, all right. If you that he is passing urine, passing blood in urine, said okay, that's fine. Or if he's a root patient, the patient will say, doctor, how can that be all right? So just watch it, because yeah, just take note of that. Okay, all right. It cannot be okay and all right. And
Yeah, he could maybe say, I'm really sorry to know that.
Yeah, exactly.
Yeah, but maybe why I understand, because it's first time he's presenting and he understood, and that's why he was saying, okay, all right.
Yes.
Because in that flow he was saying it that way. Didn't mean it. He didn't mean bad. Not at all. This is very good, Dr. Fabian. Yes, something he will remember.
He will watch. Yeah, he should take note of that.
Yes.
That's all.
Good. Thank you.